This is Module 3, Assessment and Intervention Planning. Assessment and Intervention Planning comprises 24% of the licensing examination. Keep in mind what I said earlier in one of the earlier modules, that although there are distinct areas, there's 4 distinct areas, that all of the areas overlap with one another. But about 24% of the exam will focus on assessment and intervention planning. So, if we think about the process of intervention planning, what does it include? It includes exploring and collecting relevant information, which we also call data. And just for your information, on the licensing exam, they could call it information or they could call it data. So it's the relevant information that we collect. It includes assessing, it can include contracting, working, and evaluating. The purpose, it's very important for us to explain the purpose of assessment to the client that we're doing the assessment for, because we are asking a lot of questions in an assessment and we always want to be clear about why we are doing that. In the initial session of assessment, if there is more than one, sometimes there's only one, often there's only one, but we really are asking a lot of questions. So we're eliciting the information, so we want to be clear with people why we're doing this. And the next step is we are looking at the meaning of the information we collected and the significance. And when we've gathered enough information, we analyze it, and in collaboration with the client, we integrate the data into what we call a tentative formulation of the problem. Social workers assess utilizing what we call the strengths perspective. We believe in the social work field that every person has strengths, and that we want to really build on those strengths and help the client identify their strengths. Biopsychosocial assessment is done with individuals so that we can reach a diagnosis and then eventually an intervention/treatment plan. So it's assessment, diagnosis, and treatment. We never come up with a diagnosis or a treatment plan without conducting an assessment. Always remember, on the licensing exam, you assess first. You gather the information. And so a little bit more about the process of assessment is collecting the information, as I said, regarding the concerns or what we call the presenting problem of the client. They are the problems that initially are presented to you at the assessment. We know in the social work field that sometimes presenting problems are not the most significant, but they are what the client shares with you, and that's what we will look at. Exploring is the process of actually asking questions and always seeking clarification from the client to make sure that we understand exactly what they are telling us. We ask questions about the biopsychosocial history, the nature of the life issue, and the social and the cultural context. Sources of data are the client's verbal accounts as well as the social worker's observations of nonverbal presentations of the client, and often collateral information from other sources is gathered as well. After an assessment, we may develop collaterally with the client in collaboration what we call the working contract. And that will include the common ground between the services of the setting and the felt needs of the client. This is a joint venture. One of the things that distinguishes us as a profession is that we work collaboratively with clients. We don't fix them, but we work with them to develop ways to solve the problems that they present to us. When we think about goals, they should be specific, measurable, action-oriented, realistic, and timely. And setting goals is a very important part of the contracting process. The work phase is very often referred to as the middle phase of treatment. This is when interventions that have been developed in collaboration with the client are used. and the actual work is done. Some clinicians call it the meat and phase part of treatment, the meat and potatoes rather, part of treatment. Evaluation is always used. So I want to be clear about this. Social workers evaluate all of their work, whether it is a one-time assessment, whether it is ongoing work with the client. We always evaluate all of our work to see if we were successful in attaining the objectives that we set out to have. So it's a very, very important. And that's the way that we're going to know if the interventions are successful or if we need to go back. We know that assessment is a fluid, ongoing, dynamic process. And so that we need to often go back and reassess and change the intervention treatment plan. So that's important to know. If we think about advanced clinical assessment, it is actually biopsychosocial assessment, and it has a clinical or psychiatric component. So formal diagnostic assessment evaluation is always important before any treatment begins or any diagnosis, as I said earlier, is made. In assessment for mental disorders, you use the exact same process, but focus on collecting more data, more detailed data about mental health issues. Assessment, it's a time-limited, formal process that collects clinical information from many sources in order to reach a diagnosis, to make a prognosis, and to render a biopsychosocial formulation and to determine treatment. Assessment is a separate, specific task from intervention and treatment. And as I said, we continue to reassess if the client is in ongoing treatment to find out what works and what needs to be reconfigured. Clinical assessment includes obtaining a history from the client, evaluating the client's mental status, collecting collateral or auxiliary data from other sources besides the client, summarizing the principal findings, making a diagnosis, making a prognosis. And what prognosis means is how we think the client will do in the future, how we expect the client to do, or how we think the client might do. Providing a biopsychosocial formulation and developing an intervention/treatment plan. So, to take the client history, you begin with, of course, eliciting the identifying information: sex, age, gender, marital status, occupation. The same as you do in any biopsychosocial assessment. Then inquire about the presenting problem or the chief complaint. Make sure this is done from the client's view. It's really important to put in quotes in your documentation using the exact words of the client when they're describing their complaints and how they're feeling, their chief complaint or presenting problem. The history and the nature of what the client brings to treatment, and this usually consists of symptoms and issues that the client is able to tell you about. Past psychiatric history is a very important part of the assessment process. Previous episodes, duration, how long did a previous episode last? Treatment, what was the treatment protocol and what was the outcome? How did the client do as a result of that treatment? I've starred this, and that is make sure inquire about the level of functioning prior to the present episode. This is critically important. We want to know before the client began to have symptoms, how were they doing? How are they functioning in their day-to-day life? How are they feeling? We then take a social and developmental history, elaborating on identifying information such as social history and object relationships. What is the client's present family situation, their living situation, certainly their financial status, occupation, and it's really important as social workers that we always ask about a history of trauma, physical, sexual, or emotional abuse. That is really important part of the process. When I talk about object relationships, what I mean is how does the person get along with other people? The people in their family, the people in their life, in a work situation, That is what we mean when we refer to object relationships. Psychiatric assessment always includes, as I mentioned a few minutes ago, a mental status exam. This is really important. And so a mental status exam describes a person's orientation, their appearance, their behavior, their speech, emotions, cognitive and perceptual processes. To test for orientation, to test a person's level of orientation, you ask the person if he or she knows who they are, where they are, and what time it is, what the date is. That's how we assess for orientation. When we report on a document on a client's appearance, you want to talk about how the client looks. Clothes, posture, grooming. For example, is the person neat or disheveled in appearance? Do they appear their apparent age, etc.? Their behavior, referring to the client's motor activity, gaits, gestures, twitches, tics, and impulse control. Does he or she exhibit aggressive behavior, or are they able to answer the questions and cooperate during the time that you are conducting the assessment? You also look for what we call psychomotor agitation or retardation, meaning is the client's psychomotor function agitated or is it very slowed down? When we think about speech, we talk about volume, rate, and coherence, not the content, however. I'll talk about that in a moment. So it could be loud, it could be soft, it could be pressured, or very slow. Then we will talk about mood in the assessment. So what is mood? Mood is a pervasive and subjectively experienced feeling state. Mood is actually what the client tells you he or she is feeling. Affect refers to instantaneous, observable expressions of emotion. Affect is what you, as the social worker conducting the assessment, see them or observe them to be feeling and how they're appearing. It's important to note in the record what the client says he or she is feeling and how they appear to be feeling in order to distinguish incongruence. So a person's feeling state and what they report to you might be very different. So we're always looking for congruence. If the person tells you they're feeling fine or good, this is an extreme example, but there are tears running down their face, you know that that is what we call mood incongruence, okay? And just a little hint, you won't see this in the textbooks, but clients complain about their mood but not their affect. Because when they're reporting about their mood, they're telling you how they're feeling, okay? They're not as aware of their affect because they're not observing it. You are observing it, that's the difference. So terms that describe affect are terms like labile, which is an important term to know, and that's about suddenly changing, cries, then quickly laughs, or a very flat affect. Flat and blunted are very similar, not a lot of emotion, it's not a full range. And constricted is another one, and that is a very narrow or constricted affect. Full or broad affect. The person presents with a full range of emotions, and you observe that when you're observing their affect, or very inappropriate affect, are some of the terms that you can see describing moods. Moods can be high or they can be low. Normal mood is called euthymia. Moods considered high, such as in bipolar disorder, which we will talk about a little later, can go from elevated to euphoric and can actually increase into what we call expansive. Dysphoria is any mood that the client experiences as unpleasant, such as anxiety, apprehension, irritability, or dysthymia. Dysthymia is low mood, and it can be a symptom of depression. DSM-5, Diagnostic and Statistical Manual 5, is simply, that's the DSM-5, and it talked about a lot in the field of social work and psychiatry, and what it is basically is a classification system. What I always say to students is, DSM-5, the DSM-5 is not a Bible. What it simply is provides us with a system that classifies mental disorders. So whether or not the client meets the criteria for a mental disorder. Mental disorders, in order to be diagnosed, must be significant and seriously infringe on the person's life, on their day-to-day functioning. It's not garden variety unhappiness or a bad hair day. It's really serious enough that it's impairing their functioning. And so that's DSM-5. And DSM-5 also, I know we're up to delusions, but I'll just mention that it does not discuss etiology. It does not tell us what causes a mental disorder. Let's talk for a few minutes about delusions. What are delusions? Delusions are false, fixed ideas. They distort thought. DSM lists 6 types of delusions: erotomatic, such as when a person believes that someone is in love with them who is not. However, the person does exist, but they are not in love. The person has a delusion. Grandiose, which is an inflated sense of self-worth. Jealous. Person believes that others are jealous because they are this or they're that. However, it's not true. It's a delusion. Persecutory. People are doing things to get me. Somatic. The person feels that something's going on in their body that actually is not going on. Or mixed. Person has elements of different delusions, of various delusions. Remember that it is when delusions are fixed that they really become problematic, because they distort the reality of the person or the thinking of the person. So that when they're fixed, they can be very problematic. You also want to remember that with delusions, there is always a little bit of truth. So does that person who I think is in love with me exist? Yes, they do. They do exist. However, they're not in love with me. So there's a little bit of truth in there's some reality in the delusion. And the other thing to remember is that you never ever confront a person who's having delusions head on, because to them, they're real. They really believe it. What you would want to do as an example, if you were working with somebody who had an erotomatic delusion, the way I would approach the person is to ask them, well, I hear what you're saying. I'm wondering, for instance, what have your other romantic relationships been like? So that you begin to explore, but you're not saying to the person, come on, you know that's not true, which I know none of you would do. That's a pretty extreme example, but just to point that out. So there's always a little element of reality there. When we think about or talk about obsessions, we're talking about persistent, intrusive, and unwanted, and I want to emphasize unwanted thoughts, and are a type of disturbed content. Whereas delusions are about thought, obsessions are about content of the thoughts. Now, with obsessions, people do not want these. It's very upsetting, it's intrusive, it's not wanted. Compulsions are senseless repeated deeds that are considered behaviors, not thoughts. But since they arrive from obsessions, the two are often reported together. Such as, something awful may happen to me if I don't perform this particular action, as you might see in hand washing. So the thought is that it's really important for me to perform this action so I don't get sick. I have to compulsively wash my hands. So the compulsion is actually the acting out of the obsession. But you can have obsessions without compulsions. So it's important to be aware of that. Very often you see them reported together though. Hallucinations. So hallucinations are different from delusions in the way that they are false perceptions in the senses, but they're not based on any external reality. Remember, we said that there's a little bit of reality in the delusion. Hallucinations are not based in reality. A lot of times clients do not admit they're hallucinating. Hallucinations distort perception. So whereas delusions distort thought, Hallucinations distort perception. There's 5 main types. Auditory is based on hearing. It's often seen in the illness of schizophrenia, and it's called, very often you'll see command hallucination. That is a hallucination that you should absolutely know because you could be asked about it on the licensing exam. Visual, often you may see in schizophrenia, seeing something that's not there. Gustatory is about taste, tasting something in your mouth that is not there. Smell is olfactory. Sometimes clients will report to you, smell that smell of rotten eggs, even though there is no smell. Remember, hallucinations are not based on external reality. Somatic, the false perception that something is in my body. Tactile is touch. This is much rarer. You used to see tactile hallucinations back in the day before we had the very good medications we have now to detoxify or stabilize someone who is addicted to, for instance, the drug alcohol, which can be life-threatening. And before we had the medications that we use today, the people who were detoxing would get the sense of having something, for instance, snakes on their body. And of course, it was very, very distressing. You don't see as much tactile hallucinations. The main two that you should be aware of are visual and especially auditory command hallucinations. Ego functions. We talked earlier about ego strength and the importance of the ego in helping us to get through life. And how does the ego develop? Well, ego development occurs as a result of having your basic needs met, identification with other people, learning, mastery of developmental tasks, effective problem solving, and successful coping. The ego develops capacities to function in the world known as ego functions, and it enables people to function in a coherent, organized manner. Not maybe every second, but in general. And the ego helps us to deal with life. The goal of the work with our clients is always to strengthen the ego, which increases the ability of clients to problem solve, be empowered, to take action on their own behalf, and to get through life with a certain level of resiliency. So ego strength is really important, and is important for us to think about in our work with clients. The ego functions are judgment, of course, which develops over time. So think about a 3-year-old does not have the judgment that a 10-year-old has, does not have the judgment of a 17-year-old, and certainly a 17-year-old doesn't have the judgment of an adult. For instance, we know today we have research that tells us the human brain is not fully developed till the age of 26. Judgment develops over time. Memory is another ego function. Cognitive functions, which also increase and develop. The delay of impulses, the ability to delay our impulses is a really important ego function because someone with poor impulse control has more trouble getting along in the world and on a day-to-day basis. Management of emotions, the ability to self-regulate is crucially important in a person's life, and it is an important ego function. If you think about someone who has poor or has dysregulation of their emotions, they have a much more difficult time in life in general, whether they're a child or an adult. So this is an important ego function. Object relationships. As I mentioned earlier, this is different than object relations theory. Object relationships is about how do you get along with other people. Again, this function is incredibly important in life. And reality testing. Can a person distinguish between fantasy and reality? These are all very important, and they're called ego functions. Let's think and talk for a moment about defenses. Egosyntonic. What does that mean? It means that when a client is very comfortable with the system, with their symptoms, this is more difficult to work with. So I gave you the example of a delusional client. A delusional client is not uncomfortable the way someone who has an obsession is, an intrusive thought that's unwanted. The person, for instance, who has an erotic manic defense is very comfortable with it. They know the person's in love with them. They're clear. Okay, can be challenging. Of course, it's workable, but it's called egosyntonic. Egodystonic is when a client is not entirely comfortable with their symptoms. So we mentioned again obsession. So somebody is talking about not being comfortable about this unwanted thought or obsession. Your goal is always to change egosyntonic thoughts to egodystonic. It's a process. It doesn't happen in 15 minutes, but that's our eventual goal. Defense mechanisms operate out of conscious awareness for the most part, while coping mechanisms are conscious. Defense mechanisms protect individuals from intolerable or unacceptable impulses. Effective defenses really are important in life. They enable us to function optimally without undue anxiety, while maladaptive defenses distort reality and impair overall ego functioning. It's when they become maladaptive that it's a problem. This is a list of some of the ego defenses that are important, and I won't go through all of them. I would urge all of you to review them and read them. Just as an example, denial is about denying something that's happening because it's too painful or makes the person too anxious to acknowledge it. You see denial in substance abuse in families that are experiencing substance abuse. So that's one example, but I would urge all of you to review these defense mechanisms. Let's move on now to depressive disorders. Depressive disorders really extend to the whole person. So the body, mind, and spirit are all affected. When the average person talks about depression, they're actually talking about dysthymia, which is a feeling of being blue, sad, down, unhappy, or feeling demoralized. All of us can experience dysthymia. You can be having a bad day, a bad week. You can be overwhelmed, exhausted. That does not necessarily mean that you're depressed. Depression is a diagnosis. Very often, when you hear someone say something like, this is the worst day of my life, or I'm so depressed, it's not actually that they're experiencing depression, but they're feeling dysthymic. Depression is actually a syndrome consisting of a mental disorder that has many signs and symptoms. DSM-5 contains several new depressive disorders that were added for the research that was done in developing DSM-5. DSM-4, when it changed over to DSM-5, the committee that developed DSM-5 did so based on a lot of the research evidence that has been done over the last number of years. So it deleted some diagnoses and it added some. The two of the new additions were disruptive mood dysregulation disorder and premenstrual dysphoric disorder. Disruptive mood dysregulation, I forgot to put the disorder there, was added to address concerns regarding the overdiagnosis of children with bipolar disorder. There was a lot of diagnosing of young children with bipolar disorder and medicating them. And so this actually, and there was a lot of concern in the psychiatric field regarding this, and so this, as a result of the research, was developed and added to DSM-5. So it's included for children up to age 18, from age 6 to age 18. Before age 6, you would not make this diagnosis because many children have temper tantrums, as all of you who are parents know. That does not mean that they have a mental disorder. So not before age 6 and not over age 18. And what you see is the child exhibits persistent irritability and frequent episodes, and I mean frequent, of 3 or more a week actually, of extreme behavioral control. You do not have to know all the specifics, you just want to know what it is. Let's talk about major depressive disorder. Okay, MDD, you might see it, the abbreviations. So the first essential feature of major depression is either a depressed mood, you have to have one or the other, and very often clients present with both, or anhedonia. A very important term, what anhedonia is a pervasive loss of interest in activities that I used to get pleasure from. I've lost my interest. I no longer get pleasure from it, but I used to. And mood, the mood of someone who's depressed could be sad, it could be irritable, it could be apprehensive. Clients often will describe to you feeling dead inside, or extremely physically drained, or they could be really, really overwhelmed. So, we talked about having one essential feature, either or, feeling depressed or anhedonia. And then you have to have 4 other symptoms. And they could be loss of appetite, weight loss or gain, that's unintentional. DSM-5 talks about 5% gain or loss. That does not mean for someone who's been on a diet or is trying to gain weight. It's about unintentional weight gain or loss. Too much sleep or too little sleep. So insomnia or hypersomnia, psychomotor agitation or retardation, lack of energy or fatigue, and very often this can be extreme. People talk about feeling so fatigued. And diminished libido is very often part of the picture, part of the clinical picture. So again, a mood change, depression usually, or anhedonia, and 4 other symptoms. And these symptoms must exist every day for at least 2 weeks. So you cannot make this diagnosis if someone comes in and tells you they've been feeling like this for a week. However, if you stop to think about it, most people don't even go to get diagnosed, even at 14 days. But you want to remember 14 days, 2 weeks for major depressive disorder. Then we have persistent depressive disorder, and what that is depressed mood for most of the day, more days than not, so most days, for 2 years, for children or adolescents only 1 year, and it may manifest in children or teens mostly as irritability rather than sadness or depression. Now, an important point here is that this is considered more chronic. It is ongoing. 2 years is a very long time. The thing that you want to remember about this particular diagnosis is that although it's most days the person is feeling this, they cannot feel euthymic. Remember, euthymic means normal mood. They cannot feel euthymic for more than 2 months. And why this is important is that because it's chronic, persistent depressive disorder, sometimes the person may actually feel a little bit better than others, but they cannot have a period of more than 2 months of feeling normal or okay, as you will. Some of the, so you also would need 2 or more of the following during the times when the person is depressed. So appetite gain or loss, insomnia or hypersomnia, low self-esteem, inability to make decisions, feelings of hopelessness. These are all signs and symptoms of depression. You only need 2 for this diagnosis, but remember, it's 2 years for adults and 1 year for adolescents or children. And remember that children and adolescents do not usually present in the way that adults do when they're depressed. They present as extremely irritable. What are some of the treatments for depressive disorders? The biological treatments are medication and electroconvulsive therapy. And very often students will say, electroconvulsive therapy, that's so dramatic. And it is. It is always done after everything else has not worked. Talk therapy, medication therapy, if all else fails and the person is profoundly depressed, because people with major depressive disorder can actually have some psychotic symptoms, so that the person might be so depressed nothing else has worked. It's at that point they might administer electroconvulsive therapy. And what I want to say about that is that in this day and age, it is done in a setting with It's a very small, it's a seizure, it is a convulsion, it's a seizure, but medication is given and it's a very slight seizure. It's not as dramatic as it was 30 or 40 years ago, but it's only used as a last resort. Some of the psychological treatments that have been very successful are the cognitive therapies, cognitive behavioral therapy, and it works with the person's thinking because the thought actually can increase or decrease behaviors or feelings. And so CBT has been effective. Interpersonal psychotherapy is effective because someone who's suffering from depression can actually have problems in their interpersonal relationships. So that can be very effective, and it can help actually family members understand what's happening. Ego supportive therapy is incredibly helpful with depression. Remember, we talked about ego strength and strengthening a client's ego to develop problem-solving skills and increase levels of esteem and resilience. And group therapy. Group therapy has been found to be quite helpful with people who are depressed because they realize they're not alone. Very often, if you're depressed, and with many mental disorders, the person feels alone and isolated. So that can decrease those feelings of isolation. So that can all be very, very helpful. Interpersonal therapy, as I said, works to change relationships that affect depression. CBT helps people change negative thinking and behavior patterns. Reducing the use of alcohol or other mood-altering substances, especially central nervous system depressants, can be very important. Alcohol is a central nervous system depressant. If someone is already depressed, they may turn to alcohol for relief, but it can actually compound the problem. Exercise is very important. Even if the person can only walk around the house and you have them doing it 4 times a day, if they're so profoundly depressed and have to start with minimal exercise. We know that exercise increases endorphin levels in the brain, which increase a sense of well-being. So it can be very helpful. And balanced nutrition, that the person is not just taking in, for instance, sugar, because that can increase levels of depression. So a fairly balanced diet is very important. There's some medications that you should know about for depression. Selective serotonin reuptake inhibitors, SSRIs, are the newer antidepressants that have found to be quite effective. There are fewer side effects. What I would like you to remember about psychoactive medications is that it's an art as much as a science. So what works well for one person, it does not necessarily mean it will work well for the other person. However, a lot of the research indicates that studies have found that if a sibling has been successfully treated with, let's say, Prozac, one of the SSRIs, another sibling who may experience depression can do quite well with that particular medication as well. But each person is biochemically different, and what one medication may not work, but another one might. So some of them are Prozac, Celexa, Lexapro, Paxil, and Zoloft, to name the major SSRIs. Some of the other atypical antidepressants that aren't quite as effective, they're older than SSRIs, and they have more side effects. Elavil is one that is still used to this day, and Tafranil. However, they have their side effects, and they have not been shown to be as effective as the SSRIs. Then there is another class of antidepressants called monoamine oxidase inhibitors, MAOIs. Now, there's 3 listed there: Parnate, Nardil, Marplan. You will not be asked the names of MAOIs. However, what I want you to know about MAOI inhibitors is this. There are stringent dietary restrictions, which is why they're not very often used, especially with young people. Now, they are effective. However, there are certain foods, such as dark chocolate, red wine, some aged cheeses, that can actually have a very negative effect. So rather than take a chance that someone would take this medication and then eat one of those foods, they're not often prescribed. But you could be asked on the licensing exam about them. and just know that they have severe dietary restrictions. Some of the other medications are called SNRIs, selective norepinephrine reuptake inhibitors, and some of those are Effexor, Pristiq, and Cymbalta. And what they do is work on the norepinephrine pathway. So when we think about SSRIs, they work on the serotonin pathway. SNRIs work on there's a slight serotonin, but it's more norepinephrine pathway. So those have been found to be effective. There are some atypical antidepressants. The one that is most well known is called Wellbutrin, and that specifically does not work at all on the serotonin or norepinephrine pathway. It works on the dopamine pathways. Now let's talk about bipolar and related disorders. Medication is always a major intervention of treatment for bipolar disorder. There's also many psychological and psychosocial components along with the primary biological component involved in the onset and course of this disorder. Bipolar disorders and related disorders feature both manic as well as depressive episodes. What's a manic episode? A manic episode is a distinct period in which the person's predominant mood is elevated or expansive or irritable to the degree that there's serious impairment in social or occupational functioning. So again, there's significant impairment in the person's functioning on a day-to-day basis. Very often in bipolar disorder, the mania precedes an episode of depression. The first onset of mania can actually be preceded by a medical condition or medications. So, what do we mean by that? There are some cases, they are very few, where SSRIs can trigger a manic episode. So, what do we see in that? Well, a person goes in because they're feeling depressed. They're assessed by a psychiatrist or a nurse practitioner, psychiatric nurse practitioner, and there's no history of manic depression in the family, so very appropriately, the practitioner may order an SSRI. And in a small percentage of the population, this can trigger a manic episode. Does it mean that there's underlying manic depression? We don't really know that, but you should just be aware of that. Bipolar depressions can emerge over days or weeks. They take a little bit longer. A manic episode can develop suddenly. And common prodromal, and again, prodromal means before the actual episode. So common prodromal symptoms of mania can include increased levels of activity, elevated mood, and an extremely decreased need for sleep. Manic episodes in bipolar I disorder must be characterized by abnormally and persistently elevated, expansive, or irritable mood, and persistent goal-directed activity or energy most of the day for at least 1 week. So for 1 week, you have to see this behavior before you can make this diagnosis. However, if the person happens to be hospitalized because it is so severe, at any point, even before the 7 days is up, they can be given this diagnosis. And of the following symptoms, at least 3 are present. Unrealistically inflated self-esteem, which we call grandiosity, a decreased need for sleep, person feels rested after 3 or less hours of sleep, more talkative than usual or extremely pressured speech, racing thoughts, easily very distractible, so we call it distractibility, and an increase in unrealistic goal activity that could, and also involvement in activities with potential for painful consequences. So the goal-directed activity could be, I want to make $1 million quick, I'm going to the gambling casino, and I am going to bet all of the money that we have in our bank account. It could be people have lost their houses, their children's funds, so very serious, painful consequences. High-risk sexual behaviors that have the potential for a dangerous outcome can be part of the picture as well. There are 2 types of bipolar disorder. There's bipolar I and bipolar II. Bipolar 1 is characterized by one or more manic episodes, usually accompanied by a major depressive episode, and it's highly recurrent. Bipolar 2 is characterized by one or more depressive episode, accompanied by at least what we call one hypomanic episode. A hypomanic episode, there are some differences. Manic is much more severe. It can be psychotic. The person could truly believe they are Jesus Christ, or, an inflated sense of grandiosity. Bipolar 2, you will never see any psychotic symptoms. You will see more depression, and hypomania is decreased need for sleep, maybe very irritable, but it's a much lower level than complete full-blown mania. So in other words, bipolar 1 features a mix of mood episodes, both mania and depression. And bipolar 2, depressive episodes predominate. But you will have to have in both at least one episode with bipolar 1 of mania and with bipolar 2 of hypomania. Then we have cyclothymic disorder. So remember we talked a few minutes ago about persistent depressive disorder. Well, in bipolar disorder, you have what's called cyclothymic disorder, which is more chronic, and the symptoms are ongoing for at least 2 years for adults, and again we have 1 year for children and adolescents without more than 2 months of euthymia. So that the symptoms are ongoing for most days. However, again, you cannot have more than 2 months of feeling normal, and there is evidence of hypomanic and depressive symptoms that do not meet the criteria for bipolar 1 or 2 or major depressive disorder, or persistent depressive disorder. So if it doesn't meet the criteria, then this diagnosis can be given if the symptoms have been present for 2 years. And remember, only 1 year for adolescents. What are the medications? Because medication is always a primary intervention for bipolar disorder. So they're used to treat both bipolar 1 and bipolar 2. The two main medications for bipolar 1 are lithium carbonate, which is a salt, a mineral salt, and Depakote or valproate. You might see either name on the licensing exam. The medications are usually continued even when the client stabilizes and is feeling better. So medication is really an important component of the treatment plan. These medications are classified as mood stabilizers for the purpose of these diagnoses. However, you will also see them classified as anticonvulsant medications for people who have seizure disorders. So there are anti-seizure medications as well. Blood levels are important to be done for these medications. Both lithium can have an effect on the kidneys and Depakote on the liver, so it's important to monitor blood work. Medications that are used also mainly for bipolar 2, there's a drug called Lamictal, which has been found to be very, very helpful in bipolar 2. Tegretol is also used in bipolar 2 at times, and these medications will not need as often blood monitoring as lithium or Depakote. What's some of the treatment for bipolar disorder? Psychopharmacotherapy, as I mentioned, is primary. Psychoeducation for both the client and the family and the people close to the person to help teach what bipolar is and how you can recognize the prodromal symptoms, such as the decreased need for sleep, so that people can understand how important taking the medication is. Ego-supportive therapy can be very, very helpful. Family therapy, because a family is a system and everyone is affected. And it can be very helpful for both the family and the client who's experiencing bipolar disorder to understand what's happening and to try to work through some of the issues. And group therapy as well, again, because to decrease the sense of isolation, to support other members that are involved in the group, this can be very, very helpful. Now let's talk about anxiety disorders. Anxiety disorders are the most frequently diagnosed mental disorders in the United States. And they are characterized by extreme and almost what I would call unbearable fear that disrupts the person's social functioning or occupational functioning. The DSM-5 describes 10 different anxiety disorders, and the specific disorders are always defined on the characteristics of the anxious response or the nature of the feared stimulus. So, for instance, if a person has a phobia about snakes, that would be the stimulus. So an extreme unbearable fear. And again, in anxiety disorders, the presenting problem is always the anxiety. So here are the 10 plus 1 specifier. Separation anxiety disorder, selective mutism, panic disorder, social anxiety disorder, which is also at times called social phobia, specific phobia, generalized anxiety disorder, anxiety due to another medical condition, which could be, if you think about certain physical disorders, such as thyroid disorders can cause a lot of anxiety. So we're always ruling that out, referring people. We need to know the person's physical health as well. So something could be going on. Other specified anxiety disorder or unspecified anxiety disorder. And what that means is the person doesn't meet the criteria for one of the above disorders. However, they still are having trouble, extreme trouble with anxiety. Then we have panic attack specifier. This is not classified as a separate mental disorder, but it can be used as a specifier with all of the other anxiety disorders. So what I recommend, we won't be able to go through all of those anxiety disorders, but I recommend that you review all of them generally. I think that one of the ones that I would think about as being important for the licensing exam could be specific phobia. And specific phobia, an example of that might be what I mentioned, snakes, or might be fear of being in an elevator or something like that. So just review the anxiety disorders. What is the treatment for anxiety disorders? Well, psychotherapy with ego-supportive approaches has been found to be quite effective. Cognitive behavioral therapy is evidence-based, and we have a lot of research evidence to support this for anxiety, because again, it works with the person's thinking and decreases those feelings of fear. Eye movement desensitization reprocessing, EMDR, developed by Dr. Francine Shapiro. And that is a type of therapy that has been found. It's a body-oriented psychotherapy that has a good amount of research done, and it involves the eyes moving, watching an object, or some tapping, and that has been found to be successful. Then we have dialectical behavioral therapy, DBT, developed by a social worker. I'll think of her name in 2 minutes. However, this is about it's a mixture of Western and Eastern, and it has benefits in the way that it provides clients with a toolbox, so to speak, what to do when the anxiety comes up. It's also, her name is, by the way, Dr. Marsha Linehan, and she is a social worker, and it has been found to be extremely effective with self-harming behaviors such as cutting for young people, but there is research indicating now that it can be very helpful with anxiety disorders as well. Group therapy, again for the reasons that we've mentioned, and that is to decrease isolation, to have support. We're all in the same boat, so to speak, so that I am not alone suffering from this. And psychopharmacotherapy, although it is not as effective as some of the other treatments, but we will talk about some of the medications for anxiety disorders. So they are called anxiolytic or anti-anxiety. Benzodiazepines can be quite effective for anxiety. However, they're highly addictive. They are central nervous system depressants, so they do relax the person and decrease the anxiety. But because they are so addictive, the person builds a tolerance. And as they go on, they need more and more of the substance to get the same desired effect, which is the relief of the anxiety. And they're highly addictive, so they really need to be given sparingly, but they can be effective. Buspar is an anxiolytic which is not addictive, and however, it takes 2 to 6 weeks to work, like antidepressants. So that, an anti-anxiety medication such as Valium works immediately. Sometimes people are suffering so much they don't want to wait. But Buspar has been found to be effective. It's not addictive. If the person runs out of their medication and doesn't take it, they will not go through withdrawal. There can be serious, even life-threatening withdrawal from Valium if the system has become used to it. Antidepressants, SSRIs, such as Zoloft, Paxil, Prozac, and Celexa, have been found to be, in small doses, quite effective. We do know that anxiety can be a hallmark of depression, so they have been found to be effective. Now we're going to move on to schizophrenia spectrum and other psychotic disorders. So, DSM lists a number of them: delusional disorder, brief psychotic disorder, schizophreniform disorder, schizophrenia, schizoaffective disorder, substance or medication-induced psychotic disorder, because we do know that there are some substances that can induce psychosis if they are taken. Psychotic disorder due to another medical condition, catatonia, other specified schizophrenia spectrum and other psychotic disorder, and unspecified, when the person has some symptoms that don't meet the exact criteria for one of the above diagnoses. So what is psychosis? When we think about psychosis, what is it? It's a generic term. It means a break with reality. It's a symptom, not an illness. So schizophrenia, for instance, is an illness. The person has psychotic symptoms. So psychosis actually comprises symptoms, and is caused by a variety of conditions that affect the functioning of the brain. It can include hallucinations, delusions, and thought disorder. Psychotic symptoms. There are 5 ways a person can be identified as psychotic, and they are delusions, hallucinations, disorganized behavior, and what that is behavior that is not goal-directed, such as removing your clothes in public, disorganized speech, which is also called loose associations, and what that means is that the person is not connecting. Their speech is not connecting to coherent associations or thought, and negative symptoms, which we will talk about. Any psychotic client must have at least one of these symptoms, but a client diagnosed, for instance, with schizophrenia has to have at least 2. We'll talk about that. Therefore, the task in diagnosing any psychosis is to determine the extent of the psychotic symptoms. What are some of the terms that you should know about psychotic disorders? Alogia is one, and what it means is the absence of speech. And it refers to a disruption in the thought process reflected in the person's speech. One form of alogia is called poverty of speech, meaning that the speech is brief, very limited, and emerges only in response to questions or prompts versus flowing spontaneously. So remember, we're talking here about psychosis. There are many times in a person's developmental life, if you say to an adolescent, "How are you?" "Fine." "Where are you going?" "Out." That does not mean that they have psychotic symptoms. They may have a little poverty of speech, but it's not an actual mental health disorder. We're talking here about symptoms leading to mental health disorders. Another form of alogia is poverty of content, and that's when the information or concepts that the individual is attempting to tell you is missing or very obscured. Avolition is a lack of effort to act on your own behalf or to engage in behaviors to accomplish a purpose. Affective flattening or blunted affect refers to a decrease or low level in emotions, shown as a wooden quality or near absence, it's flat, of emotionality. In the diagnosis, in psychotic disorders, we have something called positive symptoms and negative symptoms. So when I think of positive, I always think of adding something, and negative is taking something away. So I want you to remember that. It's an easy way to remember. So positive symptoms refer to a factor being present that does not normally occur or to some excess of some factor or behavior. So what are something that's added? Could be hallucinations that weren't there before, they're added. Delusions, strange bodily movements or what we call frozen bodily movements, disorganized or peculiar speech, again the loose associations I mentioned, or disorganized or bizarre or primitive behavior that is considered to be socially inappropriate. Those could all be positive symptoms. Now your negative symptoms, referring to an absence or deficiency of a factor that's usually at a reasonable level during normal functioning, they could include avolition, remember, little motivation to act on your own behalf, flat or blunted affect, alogia, poverty of speech, social withdrawal, anhedonia, remember that's absence of pleasure in things I used to find pleasurable, non-communication, or severe ambivalence in decision-making. Those would be considered negative symptoms. Disorganized symptoms, so you have disorganized speech, which is incoherence, inability to organize the ideas. Loose associations, which is a type of derailment. The person rambles, difficulty sticking to one topic or linking them together. Disorganized behavior is odd or peculiar behavior. It could be silliness, agitation, unusual dress, such as wearing several heavy coats on a 90-degree day. So we're going to talk about a few of the psychotic disorders. We won't go over every single one of them. You can review them on your own. Let's start with brief psychotic disorder. People with this illness have sudden short periods of psychotic behavior, often having to do with an extremely stressful event, such as a death in the family. Recovery is often quick, usually less than a month, and sometimes in a day or two. The shock of the loss could be so overwhelming that the person actually develops some psychotic symptoms. The person will have the presence of one or more delusions, hallucinations, disorganized speech, grossly disorganized, or catatonic behavior. Catatonic meaning the person just becomes frozen. With or without, you can use a specifier, such as with or without marked stressors. With postpartum onset is another specifier that you might add. Duration is 1 day to 1 month. So you will never give this diagnosis if it is over a month. And you're always excluding mood disorders, schizophrenia, substance, or general medical condition, because we know medical conditions can cause this too. For instance, a brain tumor could actually cause someone to have psychotic symptoms. So just remember, it's very telling, the word brief lets you know that it's less than a month. We're going to talk about schizophrenia, which is one of the most devastating mental health disorders. And what are some of the possible early signs of schizophrenia? Many individuals who develop schizophrenia display what are called premorbid or early warning signs, okay, before the illness. And some of them are a slow, gradual development of symptoms, social withdrawal, loss of interest in activities, real deterioration of self-care, and a variety of odd behaviors. And these behaviors are really very difficult for families and friends to understand, because with schizophrenia, what you usually see is the first onset of the illness. The first episode usually happens in late adolescence or early adulthood, certainly for males. For females, it can be even into the 30s, but it's usually late adolescence or early adulthood. Families are devastated because as a child or even in puberty, the person was developing normally. Very often, the first episode happens in college. So, but some of these signs might have existed for many years, but when present, do not guarantee the onset of schizophrenia. So if you see any of those symptoms, that doesn't mean necessarily the person's going on to develop schizophrenia. So according to DSM-5, schizophrenia is characterized by 6 months of continuous symptoms and signs of the disturbance. So remember that brief psychotic disorder, what we said is that over a month, you would not diagnose it. You have to have symptoms for 6 months. This is a very serious diagnosis, so it's 6 months. Criterion A, one or more of the following is present for a significant portion of the time during a 1-month period, and at least one of these must be present, okay? So for a month, you're going to have delusions, hallucinations, disorganized speech, grossly disorganized behavior or catatonic behavior, negative symptoms such as flat affect, avolition, alogia, chronic deteriorating of functioning is criterion B. Continuation of symptoms that exceed 6 months. So that for 1 month you're going to have one of the first 5 that I mentioned, but you're going to have symptoms for 6 months. And chronic deteriorating of functioning is a big one. The absence of a criterion C, well, that's the continuation of symptoms, and D is the absence of a concurrent mood disorder, substance abuse, or general medical condition that would explain the clinical presentation. It's important. So remember I said a brain tumor could actually cause psychotic symptoms. So we're always ruling out medical illness. As mental health practitioners, it's important for us not to forget the physical. It's mental as well as physical is very important. That's why as social workers, we do, I think, such an excellent job because we focus on biopsychosocial. Now let's focus on what we call schizophreniform disorder. And you need to be able to differentiate between schizophreniform disorder and schizophrenia. And it's very similar, except for the criterion of duration. So except for duration, they look very, very similar. But with this diagnosis, a person can completely recover. In most cases, in all cases actually, right now we do not have research that tells us you can recover from schizophrenia. It's chronic. It's a chronic mental illness. Schizophreniform you can completely recover from. And if the client has symptoms of schizophrenia and the active and residual phases have persisted for more than 1 month, but less than 6, he or she should receive the diagnosis of schizophreniform. So they may have, in fact, schizophrenia, but if it's under 6 months, you can give this diagnosis if they have those symptoms. It may be that the client has schizophrenia, but if it's less than 6 months, we do not want to give that diagnosis. Then we have what's called schizoaffective disorder. You must also differentiate between schizophrenia and schizoaffective disorder. So a person who has schizoaffective disorder experiences a continuous period of mental illness featuring symptoms that meet criterion A for schizophrenia. That is your hallucinations, your delusions, that are concurrent at some time with either a manic, a major depressive, or a mixed mood episode. This diagnosis is sometimes, interestingly, considered halfway between schizophrenia and bipolar disorder because you can have symptoms of both. Another way to conceptualize schizoaffective disorder is that it actually resembles bipolar disorder that never quite stabilizes. What's the treatment for schizophrenia spectrum and other psychotic disorders? It should always be multimodal. It should include interventions that are targeted at specific symptoms, so symptom control is quite important, as well as the social and educational needs of the client and family. So psychoeducation is very, very important. Remember, families can be devastated. Treatment should include assessment, which should be extremely extensive, a real differential diagnosis, medications are usually indicated, and psychosocial interventions because the person's whole life is affected. some of the medications that are ordered very often for psychotic disorders? They are called either antipsychotic or neuroleptic medications. Both names are acceptable. We have our first generation, which are called the conventional first generation medications, and they are Thorazine, Prolixin. Prolixin is very similar to Thorazine, but it's injected only once a month rather than daily to increase compliance. There's a medication called Navaine, L'Occitane, and Haldol, which are first generations and quite effective medications. They, however, have a lot of side effects. Some of the newer second generation medications are Abilify, Risperidone, Clozapine, Olanzapine, Quetiapine, Seroquel is the other name that you probably know it by, and Geodome. These medications are quite effective and have fewer side effects, but that's not to say that they don't have side effects. They do. And so the side effects of all these medications really need to be respected. And social workers do not prescribe, but we monitor compliance of medications. And it's really our job to find out how the client is doing on the medications and report back to the treatment team and the prescriber of the medications. So what are some of the side effects? Medication is always a primary intervention modality, as I said earlier, in psychotic disorders. And some of these medications can cause something called akathisia, which is restlessness and agitation, and dystonia, which is muscle spasms. The main symptom, side effect that I want you to be aware of and is almost always asked about on the licensing exam is called tardive dyskinesia. And that is involuntary movement of the face and limbs resulting from antipsychotic medications. And it can be permanent. The older first generation medications are much more likely to cause this. However, the newer ones can as well, but it's less likely. And the problem is that it can be permanent, so it can be very dangerous. There are some medications called anticholinergic medications that oppose the action of acetylcholine caused by some of these medications. They are called, and I'm telling you this more for your information, I doubt very highly you would be asked about this. They are cogentin, Artane, and even Benadryl, the antihistamine, can counteract some of the side effects. So in inpatient treatment, you may see someone being prescribed these medications if the person is really experiencing terrible side effects from the antipsychotic medications. So just a little bit of history. Thorazine was the first medication to be used in the 1940s. Again, it was the first one that could really help people with illnesses such as schizophrenia. However, it has a lot of side effects, as I mentioned. Haldol came along in 1958. Again, has side effects, but very effective. Risperidone came about in 1994. It's still used today. That is a newer, second generation. Zyprexa in 1996. Again, that's a second generation, newer, and it is a good medication. However, what we have found is that it can have severe implications for developing adult onset or type 2 diabetes. So you may not see that quite as often. We thought when it was first developed it would be great, and it is good medicine, but it can cause a problem. Abilify is a second generation also, and it was first used with schizophrenia, the illness of schizophrenia in 2002. It began to be used in bipolar disorder in acute manic episodes in 2004. So in manic episodes, it can often be ordered. However, the person will not stay on the antipsychotic medication. When the person stabilizes and the manic episode is over, they usually take the person off Abilify, but they leave them on the mood stabilizers, such as Depakote or lithium. It began to be used in 2007 in major depressive disorder, usually in conjunction with other medications that I mentioned earlier for depression. And in small doses, they felt it would boost the effect of the antidepressants. And in children with autism in 2009. So we know that medication is a primary treatment And it's necessary, but the side effects, as I mentioned earlier, really need to be respected and very closely monitored. Psychoeducation, family therapy, and ego supportive therapy are all extremely important treatments. Now let's talk about trauma and stressor-related disorders. According to DSM-5, there are 7 listed trauma disorders. The first is reactive attachment disorder. Next is disinhibited social engagement disorder, post-traumatic stress disorder, acute stress disorder, adjustment disorder, other specified trauma and stressor-related disorder, and unspecified trauma and stressor-related disorder. What are trauma and stressor-related disorders? Well, trauma and stressor-related disorders include disorders where there's been exposure to a traumatic or extremely stressful event. And there is psychological stress following that traumatic event, and it's variable, and that is why the change has occurred after the person has experienced that event. If we think about post-traumatic stress disorder, the person must have symptoms for 1 or more months. If it's less than 1 month, what would be important for you to remember is that that would be a diagnosis of what is called acute stress disorder. There are 4 symptom clusters in post-traumatic stress disorder, and the first is re-experiencing the event, avoiding the traumatic event, or anything that reminds the person or triggers the person about the event that was traumatic or extremely stressful to them. Persistent negative alterations in mood and cognition. And arousal describes behavioral symptoms that go along with the diagnosis. DSM-5 more clearly defines what contributes to a traumatic event. And in DSM-5 versus previous DSMs, sexual assault is specifically included. And then reoccurring exposure that could apply to not only the person who has experienced the stressful event, but to first responders of the traumatic event. The other change to DSM-5 from DSM-4, which is very important, is the recognition of PTSD in young children. The criteria has been made more developmentally sensitive, and it's been modified for children age 6 and younger. Diagnostic thresholds have been lowered for children and adolescents. And furthermore, separate criteria have been added for these children that make it more accessible to create a diagnosis for young children who have experienced this. Then we have acute stress disorder. Now remember, I said a few moments ago that acute stress disorder is a shorter duration. So if the person experiences a traumatic or stressful event, the acute stress disorder, the duration would be 3 days to 1 month. So if it's over 1 month and the person is still having symptoms, then it would change to PTSD. Under a month, it's acute stress disorder. And the criterion requires being explicit whether qualifying traumatic events that were experienced directly or witnessed or experienced indirectly by witnessing the traumatic event. And the individuals can meet the diagnostic criteria in DSM-5 for acute stress disorder if they exhibit 9 of the 14 symptoms in these categories, which could be very similar to those in PTSD, such as intrusion, meaning memories that are intrusive for the person, negative mood, disassociation, avoidance, and arousal, hyperarousal, being triggered by a stressful event. So you can have that in PTSD. You also can experience it in acute stress disorder, but it will be for a shorter period of time. Adjustment disorder is now in the section because it is known to be that very stressful events or even a stressful event which is experienced personally as extremely stressful, such as a divorce, can be really, really disruptive and very stressful in a person's life. So it's been redefined as an array of stress response syndromes occurring after exposure to a distressing event. It usually starts within 3 months of the stressor, so the onset is within 3 months, and most likely stops within 6 months of the stressor's end, so that it is not given as a long-term diagnosis, although many of us have seen that. You may have seen it at your placements or the agencies where you will be working. That's given for a longer period of time. But this is the criteria that has been set for DSM-5. Adjustment disorder can also have some subtypes which have been unchanged, which are unchanged from DSM-4. And they are with depressed mood, with anxiety, or with disturbance of conduct. So that's adjustment disorder. What are some of the treatment for trauma and stress-related disorders? Well, ego-supportive psychotherapy can be extremely important. CBT, cognitive behavioral therapy, which works with the thinking of the person because the thinking creates the feelings and the behaviors. Eye movement desensitization reprocessing, EMDR, which is a type of therapy that is considered to be body-oriented psychotherapy that works with, because we know that, what I always say to students is the body presents us with the bill. So the traumatic experiences have created feelings in the person's body, and we know that we cannot, there's no separation between the body and the mind. It's one organism. And so EMDR has a lot of research support to back it. It is a type of therapy developed by a woman named Dr. Francine Shapiro, and it has been found to be successful with many clients. Then there's mindfulness relaxation training to relax the central nervous system, has been found to be very useful. And dialectical behavioral therapy, which is a therapy that was developed by Dr. Marsha Linehan, a social worker. And she has developed, it is a combination or a blend of Eastern and Western therapy. And what it presents to clients is a toolbox of managing and regulating behaviors, such as self-harming behaviors or triggers that are linked to a diagnosis such as post-traumatic stress disorder. So it has a great, quite a bit of research evidence that shows it to be very effective. Now let's move to substance-related and addictive disorders. So there's a few terms that are very important to know for the licensing exam, but also for your practice in general. We know that substance abuse and related disorders are one of the #1 public health crises in our country. Of course, all of us know that currently in the United States, we have an opiate crisis. 66,000 people died of opiate overdoses in 2017, and 88,000 people died of alcohol-related disorders. So we're talking about large numbers of people affected by this illness. So what are some of the terms? Tolerance. Tolerance is needing more of the substance to get the same desired effect. Meaning, I used to be able to have one drink and I would feel relaxed, then I might need 2, and someone who develops what we call tolerance needs more to get that same feeling, whether it's a little bit of euphoria or a state of relaxation. Withdrawal is another important term. Withdrawal means the person begins to experience symptoms that are extremely uncomfortable, physical and emotionally. They can also be life-threatening in certain cases. Some of the drugs that can be life-threatening if the person is not withdrawn medically are alcohol, barbiturates, which would be your sleeping pills, and minor tranquilizers, also known as anti-anxiety or anxiolytic medications. They are the most life-threatening. So, for example, you know what alcohol is, the drug of alcohol can be life-threatening if the person's body has adapted and is now severely addicted and cannot function without it. If you do not medically stabilize the person, they can suffer seizures within 48 to 72 hours of not having a drink. So it's really important that they be stabilized medically. The other medication, as I mentioned, anti-anxiety medications such as Valium, Xanax, are highly addictive medications, and the person who has become tolerant or dependent on them will need to be withdrawn in titrated doses coming down, and withdrawn medically, or else it could be very life-threatening. So what you want to think about in medical stabilization and assessment is that we always refer to medical personnel, to doctors or nurse practitioners, to see if the person needs to be medically detoxified or stabilized, as we call it, because medical safety always comes first. And so again, just to reiterate, alcohol, barbiturates, and anti-anxiety dependent clients always require medical detoxification. According to DSM-5, there are 10 substances that are included in the chapter on substance-related disorders. They are alcohol, caffeine, marijuana or cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotics, and anti-anxiety, anxiolytic drugs, stimulants, tobacco, and some other drugs, and also gambling. We know that gambling is now considered an addictive disorder, and it has been newly added to DSM-5. So what about the criteria for substance use disorders? So some of the criteria for all of the substances included are using larger amounts or for longer periods of time than intended. Persistent desire or unsuccessful attempts to cut down or control use. So what that means is the person uses, they wake up in the morning and they say, tonight when I go out with my friends, I'm only going to have 2 drinks. So their intentions are that, and then when they get there, they're not able to do that. Those are some of the signs. Now, there may be many people who thought they weren't going to have any drinks when they went out with friends and had more. That doesn't mean they have a substance use disorder. So it's very important to conduct a thorough assessment. So trying to cut down or control what that means, control use. So what's an example? An example is the person decides, you know what, I'm just drinking too much, so I'm going to stop drinking or smoking pot or using any other drugs. I'm only going to do it on Friday and Saturday nights. And then before you know it, they're not able to stick to that. Then they start on Thursday night. They go back to Thursday night. Then let's start on Wednesday. So they try to cut back and are not able to. A great deal of time, attention, effort, and energy goes into obtaining, using, or recovering from substances. So in getting the substances either illegally or legally from doctors, you know, there are people who go from doctor to doctor because the desperation of being addicted to a substance is very serious. So there's a lot of energy that goes into obtaining the drug, certainly using it, and then recovering from the effects of the drug, meaning people who have very, very serious hangovers or are feeling ill the next day. It takes a lot of energy. Craving, the phenomena of craving or a strong desire or urge to use is another criteria. Failure to fulfill major roles at work, school, or home, not being able to meet your responsibilities. Persistent social or interpersonal problems caused by substance use. So I begin to have problems in my personal relationships, with family members, with friends. People are starting to get angry at me because they're not understanding why I'm continuing to use when it's causing me problems. What's going on? So use in spite of possible adverse consequences, continues. And that's part of the criteria. Some other criteria are important social, occupational, and recreational activities that are given up or reduced. The person's world begins to become smaller and smaller, and on all levels, socially, at work, recreation, things that they used to be involved in. Now their life begins to become really to revolve around the use of substances. Use in physically hazardous situations. An example, of course, would be driving while under the influence, operating machinery under the influence, use despite physical or psychological problems caused by the use. So the adverse consequences of the use, both physically, on the person's physical health, takes a toll, and on their psychological and emotional well-being, begins to be affected by the use. As I mentioned, also tolerance and withdrawal. Now, the few substances where withdrawal is not documented or thought of as needing to be medically stabilized are PCP, inhalants, and hallucinogens. Now, let me be clear, that doesn't mean that they're not addictive or that the person doesn't have adverse effects. However, in most cases, they don't need to be medically withdrawn. Still, we're always referring for medical assessment to make sure the person doesn't need to be medically withdrawn, because many individuals become dependent on or abuse more than one substance. So DSM-5 has done a lot of work in looking at severity levels. So while we always had a continuum that moved from social use to abuse and then to what we called in DSM-4 dependence, what we look at in DSM-5 are severity levels. And severity levels depend on the number of symptom criteria experienced by the individual. So mild abuse would be experiencing 2 to 3 symptoms, moderate would be 4 to 5 symptoms, severe would be 6 or more. And so severe would be a person has become dependent on the substance. Their body, brain cannot function without it, and it could be life-threatening if they tried to just stop using on their own, and so on and so forth. And DSM-5 did this because previously, not enough people who were in the earlier stages who were abusing were receiving treatment. And so hopefully this increases the opportunity for people to get treatment and for healthcare professionals to look at the need for treatment early on. Some of the interventions that have been developed recognize that a person who's abusing or has developed an addictive disorder, this is a type of crisis, and crisis in general can be an indicator that there's an underlying substance use disorder and can be a window of opportunity for the person to change some of these very unhealthy behaviors that could lead to fatal consequences. So there are some brief interventions that have been developed and have documented success, and they're short and problem-specific approaches. They look at and assess for looking at the continuum between risk factors all the way to dependence or to severe addiction where people need detoxification. And some of these brief interventions can help clients reduce their use or stop the abuse completely. So a lot of the work that is done with substance abusers, as I said, cognitive behavioral change has a lot of evidence behind it to support it, working with the person's thinking, but also motivational interviewing. And one of the things we do when we are assessing someone for a substance use disorder is we look at where they are in their readiness to change. And in doing that, we need to have an understanding of what stages of change are. And it was developed by 2 individuals, Dr. DiClemente and Dr. Prochaska. And the 6 stages they developed, actually, there's 5, some people say 5, but there are actually 6. And the first is pre-contemplation. The person does not have a perceived need to change. So on assessment, initial assessment, the person might give you something like change, problem, I don't have a problem. Maybe he or she has a problem, but I do not. Then the next stage of change is contemplation, which is initial awareness of the problem. It begins to dawn or resonate with the person that maybe there is a problem. And then feelings of ambivalence about change may begin to develop. And this is very interesting because the person is ambivalent. There's a part of them that sees there's a problem and maybe identifies a need to change, and then another part of them that thinks, not so much. That's normal, and we know that in stages of change. The next is a stage of preparation, initial movement away from feeling ambivalent and towards taking some action to change. And the statements of the person may reflect the beginnings of motivation, the person being motivated to want to make some changes and move towards healthier behaviors. Action, the person actually begins to take some real steps to bring about change. And then we have what's called the maintenance change. And this is where the person sustains change accomplished by previous actions. What's important to know, though, about the action stage is that it can actually be 2 steps forward, 1 step back. So we, as the professionals, clinicians, social workers, need to understand it's not a perfect path. The person goes forward, the ambivalence may kick in, and they may go backward a little bit. When they get to maintenance, actually they've made changes and they're ready to create plans for long-term change and to know how they will be able to do it. And again, as I mentioned, there's another stage called the relapse stage, and long-standing change we know can involve setbacks. Motivational interviewing, which is based on stages of change, has a strong evidence base behind it to show that it's very, very effective with substance abusers. Because many years ago in the substance abuse field, the way that clients were approached was in a much more confrontive manner. And research has shown us this does not work. So motivational interviewing, what is it? It's a client-centered directive intervention focused on resolving the ambivalence in the directive of change. So as I mentioned a few minutes ago, ambivalence is a normal part of every person's process when they're thinking about changing a behavior. There's a part of them that may recognize the need for change and have the desire to change, but there's also ambivalence. And what we recognize with motivational interviewing, that this is very, very normal. It's not actually a series of techniques, but a way of being with clients. So what do we mean by that? What we mean is that the clinician, the person working with the person with the substance use problem, it's really about the relationship between the 2 people. That means as much as any technique. So let's talk a little bit more about it. So motivational interviewing is based, as I said, on stages of change. And what it assumes is that motivation is fluid and can be influenced by that relationship with the client. It is definitely influenced in the context of relationship. And what are some of the tasks? Well, some of the main tasks of motivational interviewing are to work with the ambivalence of the person and also the resistance. So in working with the ambivalence, we talk about developing what we call a discrepancy. So what we mean by that is looking at how the person would like things to be, and then also looking at what's happening with their behavior currently to see, is that moving closer to their goals or further away? And the resistance, I mentioned that it is not a confrontational method because we know that doesn't work. So we actually what's called, in motivational interviewing, it's called we roll with resistance. So clinicians roll with resistance rather than being confrontational. And the ultimate goal is to influence change in the direction of health. So that's motivational interviewing, which has been found to be extremely effective. And what are some of the other treatments? Well, the treatment of choice is actually group therapy, because clients then are with other people with substance abuse disorders, and that whole notion of we're all in the same boat. It also works with reducing shame and stigma, because other people have experienced similar feelings and similar problems. It helps with problem solving, clients helping one another, which can be very, very helpful. Family therapy is extremely important, because a family is a system, and every member of the family system is affected by even one member of the system having a substance use disorder. So family therapy can be very effective, and providing psychoeducation as part of the family therapy can be extremely important and effective. Motivational interviewing, as I said, is very, very helpful. CBT has a strong evidence base, and 12-step programs have been found to be very, very helpful. Now, remember, this is considered peer support. There are no professionals leading 12-step meetings, but I will tell you that the licensing exam, ASWB, Association of Social Work Boards, that is responsible for developing all the exam, now refers to 12-step programs as a form of treatment. So should you see a question on the licensing exam, that could be an answer, that 12-step programs are a part of the treatment, and that medication-assisted therapy is very often part of the treatment. We know that what's called an agonist is a replacement medication or a substitution. I'll talk about that in a moment. And an antagonist is a blocking agent, and we will talk about that. So, medication-assisted therapy, there are no medications approved for cocaine abuse at this point in time. It is not a life-threatening withdrawal, although the person may feel a real sense of an emotional crash or exhaustion after using a lot of cocaine, but there's no approved withdrawal or stabilization needed. Narcan is a very important medication, and I want you to remember this name. It is being used across the United States, and it has actually been used since the 1960s. But in this day and age, with the opiate crisis, it's being utilized by not only healthcare professionals, emergency medical personnel, firemen, police officers, and even lay people are being trained in how to administer Narcan. It can be given by injection, as it is in the ER, and it can be given nasally. And of course, there's a training that goes involved in it. You need to get certified, but it literally reverses opiate overdoses. It is life-saving in so many cases, so it's an important name to remember. For alcohol and opiates, we have naltrexone, also known as Rivia, but naltrexone is the name that you would see, and it blocks the craving for opiates or alcohol. It's really used quite a bit with opiates. Camprel repairs the neurotransmitter system and restores balance between the neurotransmitters glutamate and GABA. Vivitrol is another name that you can remember. And what this is that it's a medication that, again, blocks the craving and is injected only one time a month. So it reduces craving, and it also increases compliance on the part of clients because of the fact that they only have to take it once a month. Then we have an older drug, which is Antabuse, which makes the person feel extremely ill if they drink the drug alcohol. So Antabuse is truly just for alcohol, and the person can end up in the emergency room with very high blood pressure and feeling extremely sick. Then for heroin, methadone maintenance, we all have heard of methadone maintenance, and it is considered an agonist medication. Okay, so it actually works on the same part of the brain that, for instance, heroin or opiates does. Then Rivia, or naltrexone, which is an antagonist. Again, it blocks the craving for the medication, for the drug rather. And then a newer drug, Suboxone, also decreases cravings and blocks the effects. Then for nicotine, a drug called Zyban, which is actually the drug Wellbutrin, packaged in a different name, and that is very effective for people trying to reduce smoking or to stop altogether. And then, of course, there are nicotine patches or nicotine gum, which can address the person's withdrawal, the uncomfortable withdrawal symptoms that go along with stopping smoking. And we know that stopping smoking is so difficult. It truly is an addiction and very, very difficult to stop. So those are the medications that are available for nicotine. So now I think we will talk about personality disorders. So according to the American Psychological Association, personality disorders are categorized by enduring cognitions and behaviors. So what we mean by that is ongoing behaviors that last a long time. And some of these behaviors are that there is a pervasive or rigidness that the person in their personality experiences. They have an onset in adolescence or early adulthood, but they become less obvious or less troublesome in middle and old age. They lead to a lot of unhappiness and impairment for the person suffering from the personality disorder. And there are maladaptive behaviors in at least two of the following areas, and maybe all three. And that would be affect. So the person's ability to self-regulate their emotions is not where it should be, and the emotions are dysregulated and extremely intense. The person may have very, very poor impulse control, such as in a person who does self-harming behaviors such as cutting. And interpersonal functioning. The person may have tremendous issues with object relationships, meaning the way they get along with other people. So, the most frequently diagnosed personality disorder in the United States is borderline personality disorder. And just a couple of words about the etiology. So we know that DSM-5 does not discuss etiology, which is the cause. But I think it's important to mention that research has shown that the etiology of borderline personality disorder is multifactorial. And it's most likely a combination of environmental, meaning coming from childhood, and genetic. So if one of the parents has been diagnosed with a personality disorder, it could more likely be possible that the next generation one of the children could have a personality disorder as well. In general, you should never, ever diagnose a personality disorder in the midst of an acute episode of another major psychiatric illness, such as major depressive disorder. Why is this? Well, you know, in major depressive disorder, you could see traits such as dependency, inability to make a decision, that could look like a full-blown personality disorder. However, the symptoms most likely could be linked to another disorder if the person was experiencing another acute episode in a disorder. Personality disorders are classified in 3 clusters. Of the 3 clusters, you have cluster A, which is characterized by odd or eccentric behaviors. So you would see paranoid personality disorder, schizoid, and schizotypal. So if you think of odd or eccentric, you would have those 3. Cluster B is characterized by dramatic, over-emotional, and very erratic behavior. And in this cluster, there are 4, and you would see possibly histrionic disorder, narcissistic personality disorder, antisocial personality disorder, and borderline personality disorder, which again is the most frequently diagnosed personality disorder. And then in cluster C, which is characterized by highly anxious and fearful affects, and you would see avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. So there are 3 clusters, and they're characterized in that manner. So what I recommend is that you review each of those personality disorders. We won't go through that here because it takes a lot of time, but I would just review them. But more important is to understand the 3 major points: the impulse control, poor emotional regulation, and poor object relationships, interpersonal problems with other people, as well as that they're divided into 3 clusters. The treatment for personality disorders. Treatment often deals with interventions that are targeted towards symptom management, because people with personality disorders, they are chronic disorders. Very often treatment is long-term, but they're continually in a state of crisis. So there is a lot of symptom management that is important. The other thing to be aware of is splitting and countertransference. It's really important for social workers to understand this. And when I say splitting, for instance, if a client is hospitalized, people are split into good and bad. So you're either all good or all bad, where we know that no one is all good or all bad. But this is what we call splitting, and very often clients with personality disorders do this. The other thing that's important for us to remember is our own countertransference, and to be so aware of our own triggers, to work in supervision, clinical supervision on these issues, because of the splitting and of the challenging aspects to treating someone with a personality disorder. Our own countertransferential issues can come to the surface, and it's important for us to be dealing with that on an ongoing basis so that it does not interfere with the work that we do with these clients. Treatments such as dialectical behavioral therapy has been found to be extremely helpful, and it gives the person, as I mentioned earlier, tools to deal with poor impulse control and behaviors such as cutting or other self-harming behaviors. Long-term therapy is often required, and in general, medication therapy has not had a great deal of success. However, there are some medications that currently are in use, but it has not been a major component of treatment. This concludes Module 3. Thank you so much for listening.